Hello and welcome. India now has about 1.9 million cases of COVID-19 and close to 40,000 deaths. India is also now the third highest in terms of COVID cases after the United States and Brazil. A big source of fear and stigma in the spread of this disease so far has been the probability of those close to an infected person contracting it. However, a global literature review conducted at the Indian Institute of Public Health, Gandhinagar, now says that 80 to 90% of family members do not develop COVID-19 after a primary case is diagnosed in the family. Every SAR or secondary attack ratio for household is now stands at about 6% in India, which is actually considerably low. So why is this happening? Is it the rate of infection? Is it individual immunity? To discuss this, I'm joined by Professor Dileep Mavalankar, author of this study and head and director of the Indian Institute of Public Health in Gandhinagar. Professor Mavalankar is an MBBS and MD in Preventive and Social Medicine from the University of Gujarat in Ahmedabad. He also holds a Master's in Public Health and a Doctorate in Public Health from the Johns Hopkins School of Hygiene and Public Health. Professor Mavalankar, thank you very much for joining us.
Thank you. I think it's lovely talking to you on this subject.
Thank you so much. So the first question, Professor Mavalankar, is since you've done this study, any further insights in terms of what this means? And can you take us through the broad findings that as you've seen them and as you've interpreted them?
Yeah. Let me give you 1 minute of background of why we started looking into this area. If you remember, everybody has been saying that this is a new virus, it will cause millions of cases and several lakhs of deaths, etc., etc. But 5 months into the epidemic, we don't see that in India. So sometime in early May, we started looking at the spot maps of cases and deaths in Ahmedabad city. And when we looked at those maps, we saw that there were very few houses where there were 2 dots showing that 2 dots, 2 cases happening in one house, which is the basic analysis which any epidemiologist can do. And this map analysis was done 150 years ago for cholera cases in London, and that is how public health started by John Snow. So that gave us some inclination that there are not many cases in one household. And that is where we started looking for data and then started reading international papers. And when we read sufficient papers, there were many papers showing a rate of 10%, 5%, even one paper shows less than 5%. So we thought, why not? And there was no secondary analysis of global literature on this. And that's why we started doing this analysis. And when we finished it in July, we were pleasantly surprised that the average rate comes out to be between 10 to 15 or 20% of cases in a household which has already a proved positive case of COVID has secondary infection in only 10 to 15% of cases, which is a good sign that, of course, the disease is very infectious, it spreads very rapidly, but within the household, in spite of close contact, the cases don't seem to be happening. In the household, there is no distancing, there is no mask, and still cases are not happening. And before a person is diagnosed positive, at least he has symptoms for 3-4 days, because normally once some symptom starts, people take home medicine, they take medicine from local shop, they take medicine from local doctor, and if it's not cured, then they go for COVID testing. And in spite of 4 or 5 days of close contact with the family members are in some ways resistant, not developing disease. So that is the main important contribution of our research.
Right, and this you said is a feature that's prevalent or has been seen across the world?
Yeah, there is many papers, largely from China and Korea, but of course there are papers from UK, Italy, USA. Of course, the variation is quite a bit. Some papers have shown 5% secondary attack rate, and some papers, one paper has shown 50% from China secondary attack rate. But most of the papers show between 10 to 20% 20%. And the ICMR study in India showed about 6 to 8%. Some of the states have up to 11%, but average is about 6 to 8% in Indian context.
So what is it telling you, Professor, at this point of time in terms of the way this virus is behaving?
So my interpretation of this is the virus is highly infectious. It spreads very fast through even minor small contacts, but that everybody is not susceptible to this virus. That large number of people within our country are somehow having resistance. I'll not use the word immunity because immunity is equated with herd immunity and vaccine-based immunity, etc. But some kind of resistance, either innate resistance or acquired resistance to this virus. And in some sense, it is not new. This should have been seen, if you remember 2006, chikungunya came, which was a new virus which came back by mutation after 40 years. It came from Africa to India and many parts, but they are also not the whole country. About 1.4 million Indians were infected and several thousand died, but not everybody was infected. So there are many such innate resistance in the body which prevent everybody from being infected.
Right. So if and could we extend that to, let's say, tuberculosis as well, or dengue and many other diseases?
Sure. If you see tuberculosis, almost 40% of Indians are infected, but the number of people who develop disease is the interplay of people, the bacteria of tuberculosis and one's own resistance, body resistance. So in this disease also, many people may be infected. For example, if you take the sero surveillance data from Dharavi, slums near Bombay, 57% are positive of the sample. So that means 57% of Dharavi is infected. But if you see the cases from Dharavi is only 2,500, whereas the population may be about 10 lakhs. So it is less than 0.25% of people are showing the cases.
Right. So so there's a supply and there's a demand. So if you were to look at it from the other side, is it likely that all those who have been in the studies are those showing less viral load, and in contrast, you have the super spreaders, and the super spreaders actually completely tilt the numbers, so to speak, or have done that in some of the cases that have been documented. So what could we be looking at?
Yeah, so some of the studies do mention that there is a lot of variation. There are a lot of families where there is zero secondary case. And there are some families which have many secondary cases in the same family. But still, if you take the transmission from husband to wife or wife to husband, it is not near 100%. It is only about 50%. So in the 50% of spouses, they don't get infected in spite of very close interaction with the patient. So it is basically, my interpretation of it is, of course, viral load of the infected case could be one, but second is also the immunity or resistance of the person who is susceptible but is not infected.
And could we, could you sort of dwell on that a little more? When you say immunity, for instance, let's say the example that most of us would be used to is saying, okay, I have a flu, but my spouse or my child does not get it for the same reasons. So is it the same analogy, or should we be looking at it differently?
I think it's the same. So even though some of the possible reasons for why people don't get infected in spite of close contact could be that there are, this corona is a family of viruses, and there are flu viruses which are also similar to corona, and there may be some cross immunity. Second is there is cellular immunity. It is not always the serological immunity or antibody immunity. And third is sometimes what is called a surface immunity, which is in the respiratory passages. The virus is not allowed to sit and infect the cells, which is very difficult to measure in that way. So there are various forms of immunity or bodily resistance to infections, various barriers to infection, and that may be the reason why, even though it is highly infectious, everybody is exposed, because if you read the literature on exposure, like when you cough at very close distance, lots of virons are coming out from droplets. So there is no reason why everybody should not be getting infected. So it's also the nature of the disease as well as the nature of the immunity.
Right. So, if coming to the concept of super spreaders, is that something that we've understood better? Because super spreaders clearly tilt the scales in many cases, or have done so, because one person may infect 50 people in a very short time, obviously in a closed space and so on. So is that something that maybe we should be studying more or trying to understand better?
So what we are now doing is a second literature review of spreading of the disease outside of the home. See, basically there are two spheres in which disease gets spread. One is inside the home, where you have continuous dwelling with the person for several hours, 12 hours, 18 hours, and during the lockdown almost 24 hours. Whereas when you go out in a shop or in a mall or in some closed space office, the exposure may be much limited. And there, the super spreader plus super spreading events. So there have been papers describing, say, a choir group in Washington State in US, where out of 60 people present, which were 2 hours practicing of choir, 55 of them got infected from one person. So it is also whether the viral load is very high, what kind of exposure you have, what kind of closed environment you have. There have been such things also in some of the Indian factories. So we are also planning to study the spread in workplaces. That's also important. Other review we have just started doing now.
Right. And are you getting a sense from all the literature that you've looked at or the data you've looked at that India or those who live in India or Indians are in any way different or more immune, less immune, same immune? Any insights there, Professor?
So my understanding is, and this is based on reading of data which is appearing on media, newspaper, and understanding Indian societies, in spite of very dense populations, if you look at the number of people infected, as gave example of Dharavi or any other slum, it is much less than what has happened in many other countries. Second is our nature of infection or the severity of infection also seems to be less, because recently we saw data saying only 1/4 of the percent, so 0.5% of the infected people in India are on ventilator, whereas in other countries it is much higher. If you see, our mortality is 2 to 3%, in other countries it 10. Better health services or much better nutritional status, much better treatments available. So in some sense there is something which has kept the numbers, and it's not only India. If you see Bangladesh, Pakistan, Myanmar, many countries, Sri Lanka is even lower than us. So not only our old health systems work, but there are some innate factors in spite of very congested population, very poor population. And there have been interesting hypotheses. One of the pathologists here has been talking about, is anemia a protective factor? And we have lots of anemia. So is that one? Like earlier we talked about BCG vaccine, malaria, etc. So there are many reasons we could have better immunological status to prevent disease from getting very infectious as well as very severe in form.
Right. So as you look ahead, Professor, and going by the rate of growth that we are seeing today, and which is obviously slowing down in some parts, though not in all parts, what's your sense here on, given what you know about this disease, given the fact that it is not such a, it does not spread with the same intensity that we thought it would spread or have the same kind of impact? What's your sense? How are you looking ahead?
What I see is that the peaks of this epidemic seem to be happening in a very localized way. If I know the Ahmedabad data a little more closely, the first part of Ahmedabad to be very badly infected and had cases was the central zone of the city, which is the walled city. And now, since last 1.5 months, that zone has very few new cases coming up. Similarly, the disease spread to outside zones of Ahmedabad, and now that is also gradually started declining. And if you see the dynamics between Ahmedabad and Surat, Surat had very low cases initially in April and May. Now Ahmedabad has lower cases than Surat, and Surat has more cases. So my sense is it will go from one place to another as effective interventions and actions happen, as well as immunity builds up. Both happen, because whatever the number of cases reported, the international literature shows that 20 to 100 and sometimes 200 times more subclinical or asymptomatic cases are there, and immunity builds up. So the epidemic will go down. And recently we have been reading, and we had interaction from a neuroscientist from UK, Carl Freeston, who has developed a new hypothesis based on European data analysis and modeling, that his view is half of the population in Europe is not even susceptible to disease. So he said that the immunity and herd immunity effect can be seen at as low as 20 to 30, 35% of infection rates, not cases, but seroprevalence rates, because 50% may not be susceptible or may not be contactable by the virus. So that is the reason that my sense is in many big cities like Bombay, it has started declining. Delhi, it has started declining substantially. So each city by city, of course, it will spread to rural areas, but the transmission in rural areas is much less because congestion is much less.
Right, and I mean, my last question in some ways for now, what's your sense? I mean, as you look at the transmission and the transmission intensity, what's your sense about the life cycle of this disease at this point of time? You know, or let me put that question differently. I mean, will we continue to see waves till there is a cure or a vaccine, or could it die out in some other way, or at least slow down dramatically?
My sense is we will not see waves in the same cities as much as the waves will pass on to other areas which are as of now not so much infected and don't have immunity. As I said, central zone of Ahmedabad, Delhi, if you see the seroprevalence average is about 23-24%. Bombay in slums like Dharavi, 57%. So if you have that high immunity, I don't see major second wave. But those areas which were not infected, of course, will keep on having. But the other thing which is not so much discussed now is we also see that the virus seems to be getting weaker and weaker, or it is hitting populations which have higher immunity. So you are seeing milder and milder cases as compared to what we saw in March and April. So that may also happen, and it has happened in the past epidemics, that as time progresses, the infecting agent becomes more and more milder. So you may have more cases, but less and less, proportionately less and less deaths or mortality.
And that's something you're saying is what evidence is already showing, at least the early signs.
Yeah. Unfortunately, the data is not available so easily to analyze and see week-wise mortality. Because if you see week-wise, we do cumulative mortality. Now, if you do week-wise mortality, even in Gujarat, which has higher mortality like 4%, the weekly mortality is 1.5% now, as compared to 7% which was there in April and early May.
Right. So, and a quick, since you mentioned Gujarat and Ahmedabad a few times, your sense on why mortality rates have been relatively higher, maybe compared to some other cities?
It is not clear. One is the central zone of Ahmedabad is very, very congested. So the dose initially, when the epidemic started, it had much higher infectivity there. There is also some evidence from the biotechnology mission labs in Gujarat that the strain which Gujarat has more infectivity or more virulence. So that could be another reason. So there could be several. Of course, Gujarat has higher level of diabetes, hypertension, obesity. Right. So that could be another reason.
Right. Last question, Professor. So what's your, you said that you are working on or initiating a couple of new studies. I mean, could you just sort of sum that up for us, and when could we expect the next round of insights?
I think the second one, the global literature review which we are doing, is on spreading outside the home. This was spreading inside the home. So secondary attack rate in office, work, casual contact, etc. So which will take another maybe couple of weeks to finish, and then it will take another 2 weeks to publish, but we will have some results. Second we are doing is, because this is global review, we are doing district by district primary data collection to find out what are the district level estimates of secondary attack rate in Gujarat by sample selecting people who had the infection and calling them. And the third study which we have planned is on the issue of this super spreading events, or are there models where we have some understanding from industry or offices or some transport areas where many cases got infected from one case, and what is the understanding and relevance of that for disease spreading in our country. So these are the 2-3 studies which we are planning.
Right. Right, and we do hope to come back to you and get your insights and fascinating data that you've put together to obviously share it with everyone. Professor Mavalankar, thank you very much for joining me and sharing your thoughts. And I do wish you and your team all the best as we continue this fight against this dreaded disease.
Thank you very much.
Thank you.